Hey guys, it's Medicosis Perfectionalis, your favorite medical channel, and we resume our discussion about this playlist, the series of lectures on pulmonology, and this is video number 30. Today we'll talk about pulmonary function tests, or PFTs. We use this parameter for most, but not all of them. By the way, in the previous videos we have talked about the lung pressures, airway resistant, dead space, lung compliance, and today is the famous PFTs. So without further ado, let's get started. Some words of wisdom from a wise man. Suffering ceases to be suffering the moment it finds meaning. Viktor Frankl, in his great book, Man's Search for Meaning. If you want a good book to read, instead of just wasting your life reading Kaplan Medical, here is a great book for you. Sorry, Kaplan, I'm messing with you. Viktor Frankl said, "Suffering ceases to be suffering the moment it finds meaning." May I borrow his thoughts and say, PFTs cease to cause suffering the moment they find interpretations. And this is Medicosis, Man's Search for Perfectionalis. This is not Perfectionalis, I made like 2 stupid mistakes here. Alright, sorry guys. First, let me answer that case of the last video. You have 3 subjects, A, B, and C. One of the subjects is normal, the second has emphysema, and the third is taking amiodarone and bleomycin together. So if he's taking amiodarone and bleomycin, it means he has an increased risk of pulmonary fibrosis. And pulmonary fibrosis is a restrictive lung disease. So we have normal, obstructive, and restrictive. Which one is which? Here is a volume here, and here's the transmural pressure. Whenever you look at the graph, you look at the axes first. The vertical axis and the horizontal. And the slope is going to be delta y over delta x. So change in volume over change in pressure. What are we talking about now? This is going to be compliance, baby. So between those 3 subjects, normal, obstructive, and restrictive, which one has the greatest compliance? Of course, it's going to be, first let's see. So let's take a constant pressure and move upwards. So this green curve, also known as A, has the greatest compliance. And since you know that emphysema has the greatest compliance because it's very easy to expand the lungs because you have destroyed all of the elastic fibers, so emphysema is going to be A. A equals emphysema equals obstructive lung disease. Which is the one with the least compliance? It's going to be the blue one, because the volume here is the least. So C is going to be the one with the least compliance. Which one? It's going to be the fibrosis. Why? Because if your lungs have lots of fibers, excessive fibers, it's very hard to really expand this lung. And B is going to be the normal guy. So, how I remember it? Okay, normal is like the normal socks. Okay, it's good, it's elastic, it's fine. Emphysema is your very old socks with a lax rubber band. It's very easy to expand this socks. There is no resistance whatsoever. But then when you leave it alone, it does not recoil. That's a socks with a high compliance and low recoil tendency, by which I mean it's emphysema. On the contrary, restrictive lung disease such as pulmonary fibrosis is like a very, 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 very strong socks with very strong rubber band that shrinks in the washing machine. It shrinks, it compresses. So the recoil tendency is huge, but the ability of you to expand it, i.e. compliance, is low. So when I was first studying this, I got like an old underwear from my drawer, from my closet, and did the experiment. That's how I still remember this stuff 7 years later. Because I'm spitting wisdom all over the place. Other words of wisdom from Penny Jordan. A thoughtful cup of tea brought to your bedside each morning means more to me than a huge bouquet of flowers bought once a year. Ordinary people read this quote and say, look how romantic this is. I look at this and remember that spirometry is done at the bedside, while residual volume is only measured in specialized labs. So, spirometry, which is done on the bedside, any freaking doctor or any nurse can do it. Just give this spirometer to the patient, ask him to breathe in and out, and that's it. And you will measure every single volume and every single capacity except one volume and two capacities, which will contain the residual volume. So what is the one volume that cannot be measured by spirometry? And the answer is residual volume. What are the two capacities that are not measured by spirometry? They are the two capacities that include the residual volume, such as the functional residual capacity and the total lung capacity. Both of these entities include residual volume within. That's why we cannot measure them by using spirometry, like father, like son. If the volume cannot be measured by spirometry, the capacities which include the volume cannot be measured by spirometry. It's called common sense. Okay, we got it. We cannot measure the residual volume using the stupid spirometry. So how can we measure the residual volume and therefore those two capacity? You have four options. 1. Helium dilution method, also known as closed circuit dilution. 2. Radiographic planimetry. 3. Body plethysmography. Whoa! Body plethysmography. Nitrogen washout is number 4. So here is everything you need to know in just one colorful graph. It's so easy. So let's start the experiment. You give the patient spirometry, tell the patient to put it in his mouth or her mouth, and then inhale and exhale. Let's do it normally. Okay, dear patient, dear subject, please inhale and exhale normally, as if in normal quiet breathing. Okay, breathe in. What's that called? This is called tidal volume. It's like a tide of an ocean or of a sea following the moon in a beautiful night. Breathe in, breathe out. Tidal in, tidal out. 500 in, 500 out. 500 what? mLs, milliliters, or cc's, cubic centimeter, which happens to be equal, by the way. So that's the tidal volume and we are done. Then we ask the patient to exhale normally and then inhale normally. And then after inhaling normally, please inhale to the fullest, to the maximum of your capabilities. So the patient inhaled. Disgusting. This is called inspiratory reserve volume, or IRV. Okay, that's the volume. Okay. Here we have a new capacity. By the way, capacity means two or more volumes. So volume is just one entity. Capacity is two or more entities because it means two or more volumes. If you add the tidal volume with the inspiratory reserve volume, together they are called the inspiratory capacity, or IC. Normal values, tidal volume is 500, inspiratory reserve volume is 3000. Therefore, inspiratory capacity is 3500 because it's 500 plus 3000 equals 3500. Doofus. Question: can you measure tidal volume using spirometry? Yes, because it doesn't include the residual volume. Can you measure inspiratory reserve volume using the spirometry? Yes. Can you measure inspiratory capacity using spirometry? Yes. Why? All of them do not include the residual volume. Let's do the opposite. Okay, dear subject, please go back to breathing normally. 500 in, 500 out. Tidal volume in, tidal volume out. Okay, after breathing out normally, please breathe out to the fullest, to the maximum of your abilities. Okay. Okay. Now he got rid of the expiratory reserve volume, or ERV. Look at the name, expiratory reserve, because it's not like in normal quiet breathing, but you have an extra reserve in case you need it. It's called expiratory reserve volume. Okay, contrast that with inspiratory reserve volume. This is above the tidal volume, this is below the tidal volume. Okay, what is the normal value? 1100. Okay, we got it. After maximal forced expiration, there is some air in the lung that you can never get out of your lung. Ooh, really? Yes. Even like if I tried my best? Yes. Even during exercise? Yes. Are there any exceptions? Yes, if I stabbed you in the chest and killed you, okay, I can get the residual volume out. And even if I stabbed you, which I will never do because I love you, there will still be some air that will never get out of your lung, and this is gonna be called minimal air. Minimal air. Okay, we got it. What is the normal volume of the residual volume? The normal is 1200. So ERV is 1100, RV is 1200. Okay, if you add these two volumes together, you have a new capacity. We call it the functional residual capacity. So why didn't we just call it like expiratory capacity? Because you cannot expire the residual volume, honey. You cannot. So we call it functional residual capacity. Ooh, question. Can you measure ERV using spirometry? Yes. Can you measure RV using spirometry? No. Can you measure FRC using spirometry? No. Why? Because it includes the residual volume. Now back to our great subject. After exhaling to the fullest, we want you to inhale to the maximum. So you're gonna exhale to the fullest. Then inhale. You can do the opposite. You can ask the patient while breathing normally, please breathe to the fullest. And then exhale to the fullest. And then you measure all of this. This is gonna be the vital capacity. And this is really important if you are a football coach and you want to measure the fitness of your players. One of the measures is the vital capacity. He with the greatest vital capacity probably has the best fitness. He who has a why to live can bear almost anyhow, said Nietzsche. He who has the greatest vital capacity can bear almost any interception, said Medicosis. Okay, if you add all of these four volumes together, you get something called the total lung capacity, which happens to equal inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. All of them are called TLC, total lung capacity. Question. Can you measure the total lung capacity using spirometry? And the answer is no, because it includes the residual volume. That's it, guys. I don't think this is hard. Okay, in brief. Tidal volume, breathe in, breathe out normally. This is tidal volume. 500 in, 500 out. Okay, maximal breathing after normal breathing. Inspiratory reserve volume. Normally, 3000. Okay, go back to normal. Okay, maximum expiration after normal expiration. Expiratory reserve volume. Normally, 1100. There is volume of air that you cannot get out of your lung, and this is the residual volume, 1200. If you ask the patient to maximally inhale and then maximally exhale, this is going to be the vital capacity. Add the four together and this is total lung capacity. Now let's do it from scratch because it's so easy. Okay, breathe in, breathe out normally. What do we call this? This is going to be the tidal volume, man. Okay, then after normal inspiration, please inspire to the fullest. Right. From here to here is going to be the inspiratory reserve volume. Okay, those are two volumes. Add those two volumes together and you have a new capacity called what? Inspiratory capacity. Because a capacity is more than one volume. It's two or more. Okay, back to normal breathing. Please, after normal exhalation, exhale maximally. And this is going to be called the expiratory reserve volume. Normal value, 1100. There is still a volume of air in your lung that you cannot get out under normal circumstances, and this is going to be the residual volume, normal value, 1200 mLs. Fine. If I ask the patient to inhale maximally and exhale maximally, the distance from here to here is going to be the vital capacity. Okay. And then if you add the four volumes together, this is the total lung capacity. How is this hard? What are the three entities that cannot be measured using spirometry? 1. Residual volume. 2. Functional residual capacity because it includes the residual volume. And 3. The total lung capacity because it includes the residual volume. Normal values, you should memorize that. Tidal volume is 500, easy. Inspiratory reserve volume, huge, 3000. Okay, here is a question for you. Expiratory reserve volume, if you look at it, it's just 1100. So why is the inspiratory reserve volume greater than the expiratory reserve volume? Because like if this is 3000, this should be 3000. So like makes sense? No. Because inhalation is an active process. You need your muscles for it. You need the diaphragm, you need the external intercostal muscles. That's normal. If you have forced inhalation, you need even more muscles for forced inhalation, such as serratus anterior, the scalene muscles, etc. But expiratory reserve volume, normal expiration, is a passive process. Okay. Then if you have forced expiration, this is going to be active. It's only using the forced expiration muscles. So during forced inspiration, you're using many muscles, mainly 5 groups. 1. Diaphragm. 2. External intercostal muscles. 3. Sternocleidomastoid. 4. Serratus anterior. 5. Scalene muscles. But during forced expiration, you're only using 2 groups of muscles. 1. Internal intercostals. And 2. Abdominal muscles, also known as abdominal recti. You got it? Okay, because you're using more muscles here, you need 3000, or you can get 3000. Residual volume is 1200. So 500, 3000, 1100, 1200. Then the capacities is more than one volume, 2 or more. Inspiratory capacities, if you add the total volume plus inspiratory reserve volume, and you get 3500. Functional residual capacity, if you add those two together, the 1100 and the 1200, you get 2300. Vital capacity, if you add all of them except the residual volume, and you get 4600. Total lung capacity is 5800 if you add them all together. So if you inhale maximally, at that point the volume in your lung is 5800, and that's the maximum that you can get. Of course, there is individual variation. Like a muscular guy with a huge chest wall probably has more total lung capacity than me. On average, men have greater total lung capacity than women. By the way, all of these normal values were done on military people in the 1930s, I think. All of them were males. That's how we got those numbers. But for females, it's gonna be slightly less. Some calculations, like this is basic algebra. Vital capacities, I've told you, is every single volume added together except for the residual volume. So you have the inspiratory reserve volume plus the tail volume plus the ERV. Okay, and since inspiratory reserve volume plus tidal volume equals inspiratory capacities, you can argue that vital capacity equals inspiratory capacity plus ERV. Makes perfect sense. Total lung capacity is the 4 volumes added together. We get it. Since these two are called inspiratory capacities and these two are called functional residual capacity, you can argue logically that total lung capacity is vital capacity plus residual volume. So volume is one entity, capacity is more than one volume. Anything can be measured by spirometry except those related to the RV. Therefore, a spirometer cannot measure residual volume, FRC, or total lung capacity. Let's focus on the residual volume that cannot be measured by spirometry. It's the volume of air that remains in your lung after maximal forced expiration. Significance, we have physiological significance and clinical significance. Physiological significance, it maintains the aeration of blood. So here is your nice alveolus, and here is your great blood vessel. As you know, your heart pumps 72 beats per minute. Your poor lungs inhale and exhale about 12 times per minute. That's why 72 is a normal heart rate and 12 is a normal respiratory rate. Since you are just breathing 12 times and the heart is pumping 72 times, you might run out of air for gas exchange. Here comes the residual volume to save the day. You have some air in your lung that remains there. This air can save you until you breathe in the next cycle and get the air in. And by the way, the residual volume, those 1200 mLs don't just stay there stagnant waiting for bacterial infection. They are changed, okay? They are recycled every time. The old will go and the new come, something like that. And this will prevent sudden fluctuation in blood gases, i.e. they smooth out those fluctuations. If you didn't have any residual volume, guess what will happen? Okay, so now we are only 12 here, so At some point, there is no oxygen here. At some point, there is lots of CO2 here. Okay, we are not getting in more oxygen and we are not exhaling out enough of the CO2. The CO2 will end up in the blood, raising the hydrogen ion concentration and lowering the pH, and you will end up with acidosis until you breathe in and out again. That was the physiological significance. Now, clinical significance in obstructive lung disease such as emphysema, I've told you the definition of obstructive lung disease. You cannot get the air out. You can get the air in, but you cannot get the air out. This will lead to increased residual volume. No kidding, because I cannot get the air in. More air will accumulate inside my chest over and over and over again throughout the cycles, and I will end up with increased residual volume. So if you do the residual volume to the total lung capacity ratio, it's going to be more than 30%. This is obstructive lung disease. So what's the normal value? It's easy, we can do it. What's the normal residual volume and what is the normal total lung capacity? The normal residual volume is 1200. The normal total lung capacity is about 5800. I'm stupid when it comes to math. This is around 21%. Normal is 21%. 30 or more, this is an obstructive lung disease because it means that you cannot get the air out because you have lost all of your elastic fibers because you are smoking your lungs out. And I'm not making fun of patients. My videos are directed to medical students. I just want to make education fun for you guys so that you can remember it forever, so that you can help patients. We're still talking about the residual volume. Forensic significance. Ooh, drama mode. If someone stabbed you, the residual volume will get out of the lung. But some air will still remain in your lung, and this is called the minimal air. Okay. How do we use it in forensic pathology? How you differentiate between a child who was born alive, then killed, or if he was born dead, called stillborn. If the baby was stillborn, he will have no residual volume. Why? Because he has never breathed in. Because at time of birth, at that moment, before you breathe in your first breath, your residual volume is 0. In fact, your total lung capacity is 0. You don't have any air in your lungs. To be or not to be, this is the question. Is it stillborn or a child homicide? This is the question. Answer, it depends on the residual volume. What do you mean? So in autopsy, so this baby is dead, but we want to know, was he born alive then killed? In case there is someone going to jail, or was he born dead? In this case, no one is going to jail. So you get like a glass of water and you get piece of the lung from the poor child. You put this piece in the water and then watch. If the piece of the lung floats on top of the water, it means air has entered in the lung, and after he was killed, there is still the residual volume in, and if it's not the residual, at least there is the minimal air in. And as you know, air is lighter than water, it has a lower density, so the lung will float. If the lung floats, it means there is a residual volume, which means this baby was born alive, he took a breath in, and then he was killed. Someone is going to jail. This is the first case. Second case, if the lung sinks to the bottom of the glass. Now it means there is no air, which means he was born dead. He has never breathed in his life. Here is an interesting inverse correlation. You get an autopsy, put a piece of lung in a glass of water. If the lung moves up, the suspect will be buried underneath the prison. If the lung moves down, the suspect will be released free and fly. Look, and enjoy freedom. So, if the lung goes up, you go beneath the jail. You stupid, idiot, evil son of a bleep. If the lung goes down, it means you're set to be free. Vital capacity, again, loved by the football coaches or any sport coach. Vital capacity is all of the volumes added together except for the residual volume, and it equals 4600, as you know. Can it be measured by spirometry? And the answer is yes. Then we divide that by the surface area of the body, because if you have a muscular guy like this, and if you have me like this, of course his vital capacity is going to be greater than me. That's not fair, so you divide it by the surface area of your body. Normal value in male is about 2.5 liters per square meter, which is the surface area of your body. Normal value in female is just 2. Causes of low vital capacity, also known as causes of being declined from joining the football team. Okay, we have physiologic and we have pathologic. Physiologic such as pregnancy. So pregnant women will have something in their abdomen. Okay, the abdominal cavity is full. Why? There's a baby. Okay, this is gonna press on the diaphragm and the diaphragm will go up. When the diaphragm will go up, there is less volume in your lungs. That's why your vital capacity is decreased, and this is perfectly normal. Pregnancy is not a pathology, guys. Just get your head out of your sphincter. Recumbent position. Okay, if you are laying down, okay, and lying on the bed, what's gonna happen? The diaphragm is gonna shift upwards because the viscera in your abdomen will relax and spread all over the place. They push the diaphragm upwards, so there is less volume in your lungs. That's why when we do this spirometry, the patient has to be sitting upright. No exceptions. Now let's turn our attention to the pathological causes of a low vital capacities. We have problems in bones, nerves and muscles. We have problems in the lungs, problems in the heart, problems in the abdomen. Bones. Kyphosis, lordosis, scoliosis, kyphoscoliosis. What's kyphosis? Kyphosis is like this. So this is your face. This is your eyes looking forward is here. Kyphosis is when your back is like this. Lordosis is the opposite. You're like a lord. Okay, you know those rich guys in the old movies? Those rich kings eating grapes upside down with their crowns on top of their heads and ear coming of their of their auditory meatus. Yes, these guys have like hunch like this, so they are, instead of just convex backwards, they are concave backwards. So this is called lordosis. Scoliosis is if we are looking to your face and you are looking into our face, scoliosis is like this. All right. Kyphoscoliosis is the combination of kyphosis and scoliosis. Neuromuscular cause, Guillain-Barré syndrome, which is an acute post-infectious polyneuropathy. Lambert-Eaton myasthenic syndrome, muscular dystrophy, post-polio syndrome, which is a lower motor neuron lesion, and myasthenia gravis. Problems in the lung, obstructive and restrictive obstructive, asthma, chronic bronchitis, emphysema, and bronchiectasis. That's why we do the stupid spirometry for patients in the pulmonology wards, because now you know, do they have a lung problem? Do they have a disease or not? Or it could be restrictive, such as pneumoconiosis, hypersensitivity pneumonidities, idiopathic pulmonary fibrosis, or sarcoidosis. Heart problem, CHF, congestive heart failure. You have cardiogenic pulmonary edema because this is your beautiful heart, and this heart is congested. It cannot receive the venous blood or this blood from the pulmonary veins, and the blood is gonna congest around your lung or in your lung, and this is called a pulmonary edema. That's why you end up with pink frothy sputum. Why frothy? Because you have a combination of air, which is already in your lung, plus water, thanks to the back pressure from the heart. Abdominal problem, a space-occupying lesion. Hepatomegaly, it prevents the free descent of the diaphragm, and it may even push the diaphragm upwards. Splenomegaly, same freaking reason, and ascites for the same flipping reason. There is a huge difference between vital capacity and forced vital capacity. Please don't confuse forced vital capacity, FVC, with the functional residual volume or the functional residual capacity, FRC. FVC and FRC are not the same. It's not okay. Vital capacity is not timed. Forced vital capacity is timed. Translation. In vital capacity, you ask the patient to inhale maximally, not necessarily quickly. And then exhale maximally, again, not necessarily quick. Take your time, patient. Okay, I'm gonna breathe in. And breathe out. Take your time. Disgusting. This is not timed. Forced vital capacity. Okay, inhale maximally, then exhale maximally very quickly. This is timed. Which one has greater value? Of course, if I have my time, I'm gonna get a higher value. I take my time, I'm gonna get more air in and more air out. But if you are rushing me because you are an SOB, I'm gonna get a lower value. It's called common sense. So normal value for vital capacity is around 4,600. For forced vital capacity, FVC is around 3600. Don't confuse FVC with FRC. FVC is timed, FRC is not timed. We have just talked about the FVC. Now we have an FEV1 over FVC ratio. You remember our patient? We told him, okay, you have to do this rapidly and quickly. Inhale maximally, exhale maximally, quickly. Okay, so breathe in, breathe out, quickly. And this volume is called the forced vital capacity. But it takes more than 1 second to do this. Most of the air got out in the first second. We call this FEV1. And this is gonna be around 80. And this is gonna be around 100. And this is a ratio. If this is 100%, FEV1 is 80%. Okay, we got it. So, ask the patient to inhale and exhale maximally and quickly. This took me more than a second. But I get the ratio of 1 second to the ratio of the entire freaking capacity. This is called FEV1 to FVC. Normally, FEV1 to FVC is around 80%, or 8 to 10, or 4 to 5. This is going to be really important to differentiate between obstructive lung disease and restrictive lung disease, and this is going to be the topic of the next video. Stay tuned and subscribe. If you are a medical student, you are struggling to learn about Legionella, Mycoplasma, Pseudomonas, Rhinovirus, Klebsiella, Staph and Strepton, E. coli, and Vibrio cholera, check out this website called Picmonic. They have pictured mnemonics for medical students, nursing students, dental students, pharmacy students, etc. Please check the link in the description below. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell to get notified. Please, guys, please consider supporting this channel on Patreon. Even $1 makes a huge difference with me so that I can make more videos in the future. Also, go to my Facebook page. I have more than 100 cases there. If you go to Patreon and choose the correct tier, I'll send you my Dropbox folders, which have many files and they are organized by systems. So you have these lectures in PDF forms about pulmonology, my lectures on hematology, my lectures on oncology, my lectures on rheumatology, acid base, etc., etc., etc. Also, I have a one-on-one mentorship courses. If you want me to call you and we'll talk over the phone and explain all of these medical topics to you, you're welcome to do that. Also, these information are available on patreon.com/medicosis. Thank you so much for watching. As always, be safe, stay happy, and study hard.